Okay. Uh, Hello, everyone. My name is David Foster. I work at HealthWise. I'm a senior director of analytics and insights, and I work on advocating for the use of health information technology to help people understand their healthcare and then become more involved in it, and hopefully get their voice into care. I was successful in advocating for the inclusion of patient-specific education in the meaningful use requirements, because I and HealthWise really believed that if we were going to digitize healthcare by funding the implementation of electronic health records and patient-facing systems, that was really important that people receive information that was contextually relevant to what was entered in the designated record set, is what we refer to as the medical records that are in these health technology systems. And today I'm really focused on things like interoperability, which will allow patients to get information from the health organizations that they're treated by, or the payer health insurance organizations that they're members of, so that they can have a comprehensive medical record from all the places where they receive care and all the places that they have a relationship that is helping to finance their care. And the dream of this, which really the 21st Century Cures Act back in 2016 was instrumental in trying to create, is that with these technologies that we really could make a difference in the way that people receive care, and people could become a part of the fabric of care in a new way as we shifted more to value-based care. And if you followed any of the model transformations around how healthcare is financed and distributed, shifting from fee-for-service to value-based care is one of the important trends. And while certainly it's very important to think about value from the perspective of a chief financial officer of a health system, value from the patient's perspective is also very important. And so at HealthWise we really try to emphasize the idea that technology can facilitate getting information into the hands of the consumer, and if we can use innovative technologies like AI, machine learning, NLP to parse a person's medical record and help them get the right content to understand that. That's something that we're really striving to do now with the capabilities that interoperability is bringing. Telemedicine is another big innovation area that COVID has greatly accelerated. We like that people are able to access virtual care and other modes of care to allow them to continue to receive care in this time where we have to socially distance. And it's kind of wonderful to see some of the regulatory waivers. And we also advocate for those becoming more permanent. So that's another area where we're working. And with Microsoft, we're exploring new ways that HealthWise might work with Microsoft. A lot of our technology solutions are in Azure today. We're HITRUST certified. We work with many of the leading health systems and payers around the country. We work with a lot of electronic health record partners and other health technology partners. And that partnership with Microsoft is an important one, where we're trying to improve care, the health that people have. We want to use data. We want to use the insights that you can get from data, and coordinate that care so the right care is getting to the right people. And so I would encourage viewers to check out the newly released Microsoft Text Analytics for Health. And hopefully we can learn more about that today. This is part of Azure Cognitive Services, that can help make sense out of structured and unstructured data. And exploring this area has been illuminating for HealthWise. We're always looking for new ways to use technology to connect patients with meaningful content that can inform them, again, and help them take action on their health. So I'm excited to introduce Dr. David Rue from Microsoft today. He is the Chief Medical Officer at Microsoft, and he has a long career in consumer technology. He's also worked at Samsung, working on consumer technologies there. He also is an infectious diseases doctor. Very important in this time that we listen to our infectious diseases doctors. I'm sure you have a lot to say about that. He also has worked on clinical decision support at a company called Zinx, which is another one of HealthWise's partners out there. So if you're not familiar with clinical decision support, essentially it's a technology tool that allows clinicians to get the best evidence-based guidelines to help them practice medicine in an effective and high-quality way. Dr. Rue is also a professor at the Stanford University School of Medicine. He has a background in computer science and cellular biology from the University of Michigan. He has worked at Cedars-Sinai and UCLA, and he's also worked with the National Quality Forum, which is near and dear to HealthWise's heart, because we believe that measuring quality is really important as we shift to value-based care. So I'm excited to hear, Dr. Rue, what you have to say about your new mission at Microsoft and how you're using technology to try to address some of these big problems that we have here.
Thank you, David. Great introduction. A lot of points of synergy. I'm excited to share more details of my journey as well as the journey that Microsoft's taken and some of the things that are happening real time that you alluded to. Again, by way of background, my name is David Rue. I'm the Global Chief Medical Officer for Microsoft. I'm a physician. I'm a technologist. I'm a health services researcher. Have spent the past 25 years looking at how technology can be used to improve health outcomes, access to care, quality of care, ways that we can reduce disparities in the care system, and then ultimately improve the overall experience for patients and providers. And as we've been thinking through, or at least I on my early parts of my journey had been thinking through that process, we started with one of the areas that we saw in the 1990s really take hold, which was the electronic health record. And, starting with that as a mechanism to be able to apply, at the time was kind of novel, evidence-based guidelines. People actually were quite resistant to it. They called it cookbook medicine. They didn't really believe that this was something that was consistent with the way that they had been trained. They had been trained that medicine is an art and there's really no need for standardization. Well, it turns out that there is an art to it, but there's a great need also when you identify through science and evidence, high quality evidence, that certain things are important and save lives and reduce costs and lead to better outcomes, that we should all be doing it. And so, these type of sources of information need to be brought to light and people need to be aware of it. And so not forcing anything on people, but just simply making it easier for them to access it. That is the genesis of what we now refer to as clinical decision support. And it started with bringing information live in the medical record through first alerts, which was a bit disruptive because a lot of times we were disrupting the workflow, but then in more workflow compatible ways like order sets and plans of care that actually provided great value because it was saving people tremendous amounts of time to enter orders into electronic health records and to do documentation. So we learned pretty quickly that to develop systems that allow us to be able to achieve better outcomes, we have to think about the clinical workflow. Well, sure enough, healthcare has been moving outside of the hospital. It's been moving towards patients and consumers and in their home and on the go. And in large part, that meant that we had to understand how these technologies could be used by patients and family members. And it turns out that a patient portal just doesn't cut it. Most patients, one, don't get the information that they all need through that. And then two, that it's not really what we'll refer to as lifestyle compatible. I mean, really, if you're talking about what people want, they want something seamless. Just the data is captured, information is presented to them when they need it, sort of this concept of right information at the right time. And so in large part, I spent the next part of my career thinking about strategies on how technologies could be used to deliver that right information at the right time and capture that information to clinicians and be able to provide that in a clinical workflow that was compatible with what clinicians were looking for. And that brought us down a journey of looking at virtual care as a mechanism to deliver better care. And we went to explore deeper beyond simply telemedicine, just reimagining what the workflow of for something that is traditionally in person. A good example would be the work that we did with Kaiser Permanente, where we looked at the clinical workflow of a patient who's had a heart attack and now is being asked to do 6 to 8 weeks of cardiac rehabilitation. Now, that's a process that typically involves a significant amount of commitment on the patient's part to spend that time coming into the facility. And because of that commitment, they may have a job, they may have transportation issues, they may have family. Less than 50% of patients complete these programs nationwide. It's actually, and then of course you add distance to that. If you live far away, you're gonna, of course, have a lower completion rate. Turns out that cardiac rehab, the number needed to treat to save one life is 7, or in some studies 17. And the fact that more than half of people aren't completing it means that there's a lot of people that dying unnecessarily, and purely because we've made it difficult for people. So what we did is we asked the cardiologist, this program, does it require an in-person facility visit? Do you have to have defibrillators right there and people standing by just in case somebody collapses? It turns out all those hypotheses and thoughts were off base. The majority of these folks were low risk. There's in fact no real monitoring going on apart from somebody standing there and just seeing if they can provide some assistance. And what they were trying to do is they're trying to enable individuals to exercise and improve their tolerance. That was the core part, and then to encourage them to take their medicines and make sure they're on track with their plan. So we virtualized that. We put it on a smartwatch, and we found that we were able to increase the adoption rate from mid 40s to mid 80s. So like a near doubling of the completion rate. And then interestingly enough, we measured the readmission rate, and it went from 12% to less than 1%. And that combination of helping patients, making it easier for them, is something that allowed us to be able to demonstrate higher levels of adoption on a proven intervention that led to better health outcomes and lower cost. Now, the challenge is, and we've run into this again and again, the data resided on a watch. The data in the electronic health record resided in the EHR. We have been struggling for years trying to consolidate and move these data sets into something that allows us to be able to understand the context of this patient, who may have COVID or may have, prior COVID, I should say, or may have heart failure or may have a variety of other conditions and just maybe of a certain age. All those factors play into our overall assessment. But without that ability to combine information in a way that is seamless, it limits our ability. Well, David, you had mentioned the 21st Century Cures Act, the CMS interoperability rules. We are now heading down the path where these bridges are being formed through open APIs and smart on fire applications and ability to create fire servers to be able to pull these data sets in. And that has created opportunities for us to be able to think differently and innovate about how right information can be brought to the point of care in the context of what we're looking at now, which is a new digital ecosystem. And that's where I joined Microsoft to really help build that digital ecosystem with the decision support tools. One of the things that we are really excited about is the launch of the Microsoft Cloud for Healthcare. The Microsoft Cloud for Healthcare represents Microsoft's first industry-specific cloud that takes all the healthcare components that we've been working on, such as the Azure components on AI and ML, the ability for us to be able to use Fire APIs, Teams collaboration with virtual care, the use of a Dynamics platform to enable virtual care navigation. All these pieces have now been assembled and streamlined in a way that allows us to be able to deploy them and solve problems that we couldn't have solved in the past without this digital connection or platform. And so let me give you an example of like a few things that gives you an idea of like what the possibilities are. So imagine a person is having a conversation with, well, maybe they're just feeling like they're having some questions of anything from the diabetes is getting worse, or I feel like I'm having issues around shortness of breath, or I just have concerns of COVID. Well, these type of questions come up all the time. And typically the first response is, well, let's go talk to the doctor or schedule an appointment. Well, in between that doctor visit and your assessment, there's an intervention that's happening that we are not oftentimes paying attention to. And that's the phone call that occurs to the receptionist or to the call center agent, or perhaps even to the first line agent, which maybe was a case manager, or there was a pharmacist that you were already talking to, or there was a social worker. These individuals that are your first point of contact actually could provide an element of triage and support and guidance if they had the right information at the right time. Now, let's imagine a scenario where you made that call to the receptionist or the call center. Your request was to simply schedule an appointment. Well, rather than just scheduling an in-person appointment, which could have taken 6 months or 3 months and who knows how long, and basing it on that person's assessment of your severity and not really clear in terms of like all the other factors, let's imagine we were able to pull from using a FHIR API from the medical record and identify 2 elements. 1, the person has been missing their last 4 appointments, and 2, they've been not refilling their medicines. And these are things that oftentimes come up later in the conversation when they see the doctor, when they see the healthcare provider in that context, and it may not even come up. They may not even realize that this person has actually had these issues. But now imagine that information then is flowing through an AI-based chatbot, which then reviews through an evidence-based protocol a series of questions that should be asked. Notice that you missed your last 4 appointments. Is it because of something related to transportation? Is it a cost issue? Is it something that is incompatible with your current schedule? And then exploring that deeper and then making it easier for the patient at that moment. Well, we can schedule a ride share, or we can give you a voucher. We can set you up with a social worker who can actually find out a job because your issue is really around limited income, or perhaps the issue is around medication non-adherence, where it's not always due to side effects, but maybe it's due to cost. Maybe we need to address those issues as well. Now, these types of triage and support can now be brought, we'll call it real-time clinical decision support, through a platform that allows us to be able to leverage things such as FHIR APIs, AI-based chatbots, and then teams and collaboration tools. And as we've gone through that process of thinking through these workflows, we've also realized that the data that needs to be captured has to be pushed into the medical record, or the initiation of the consult oftentimes needs to start from the medical record. And so as part of the announcement for the Microsoft Cloud for Healthcare, we announced things such as you can launch the team's telehealth visit directly from Epic, so that's like one element, or the conversation that I've just had with Dr. David Foster and myself as the patient is now captured through just a conversation, an ambient experience where that conversation is converted from voice to text. It's then converted from that text into something that is understandable. So it's not just words, but it actually is concepts, which behind the scene are mapped to terms, which then gets put into a medical note, which Dr. Foster can then review, make some slight edits, push a button, and then goes into the medical record. Now, that has always been a dream, a fantasy for a lot of doctors. It's real. We actually have spent a significant amount of time not only developing, but validating it. Working with sites like Nebraska Medicine, Rush University, WellSpan, been able to demonstrate that it can reduce the amount of time for clinical documentation from between 50 to 75%, improves physician satisfaction by 88%. In this day of age where clinicians are getting burned out because of everything from the issues around documentation to the disruptions in the workflow, what we're realizing is that these are tools that can be can be implemented real time and could also be greatly beneficial to them. And then what was announced was the integration of this into Teams. So now we have the ability to go directly from Teams, that virtual consult, and directly into the medical record. So what we're seeing is an ability for us to sort of rethink what's possible across the care continuum by using these tools that span digital, virtual, and pull in information from these systems of record, allow us to be able to act on them. And it doesn't have to be a physician acting on it or a nurse. It could even be frontline workers acting on it, patients acting on it, giving patients the tools that allow them to be able to provide smarter decisions. This whole concept of a chatbot is one that we've learned during the COVID experience can direct people to the right information and right resources in a very effective, individualized way. And that was something that was a finding, a new revelation that occurred when COVID first hit the States. We saw call centers being inundated. And people actually that had legitimate questions and concerns could not get through. And then those people are going into the ERs and urgent cares, and then those urgent cares and ERs were filled with other people. And so the infected were infecting the uninfected, and we were seeing spread. It was just purely because of the fact that we didn't have a scalable way to screen and triage. Well, that same concept, then we took the AI-based chatbot and converted that into a COVID screening chatbot, allowed us to be able to then take that information and convert that into something that could allow us to do that screening and assessment, and then do that virtual handoff to the healthcare provider through Teams or through the patient portal. And so now what we're realizing is that this chatbot can serve as a frontline, first-line digital agent to help us in that process for those that are digitally savvy, or you can use these other individuals and support them with the technology tools for those that would actually like to just pick up a phone and call. And the end result, just to kind of hit the punchline for this, right now this COVID screening bot is being used in over 26 countries, over 500 million COVID messages have been delivered. Like 500 million of individuals across the globe are taking advantage of this type of technology. And it's being used here in the US, across the nation. CDC, in fact, if you go to Symptom Tracker, they use this as the underlying technology. So we know this is a highly effective tool. It can be used in settings of pandemics. It can be used in settings of other disease conditions. And it's one that we also have been recognizing can tie directly into the digital workflow. So I'm going to pause. I've shared a lot. I think that perhaps maybe that's opened up some ideas or thoughts, and happy to explore further.
So I wonder if you could say more about virtual cardiac rehab. Obviously, when things started locking down, people were not able to go, to the point of care. It's almost like a metaphor of shifting from on-prem to the cloud. The patient, may really only have the opportunity to have cardiac rehab in a virtual way. Do you see a future for virtual cardiac rehab, no matter what happens with how we're able to get together?
So the studies that we did with Kaiser Permanente on virtual cardiac rehab occurred pre-COVID. It has become extremely relevant during COVID, and it is now the standard of care for how all cardiac patients in KP will be delivered cardiac rehab. So within the KP organization that has tested, validated, and shown that this has had tremendous impact, that transition has already occurred. I do think that this represents a key point of evidence to demonstrate how we can virtualize some of these programs that have never been virtualized before. I mean, not just one visit, but an entire program. And by making it easier for individuals. And so what we're learning now is that we can take, whether it's anything that has the term rehabilitation in it, is fair game. And so we can take digital tools and provide that frontline opportunity. And to give you an idea of how easy it was, there was really one choice. As a patient, you can either come in for 6 to 8 weeks, 3 times a week, spend 30 minutes or so with us on the treadmill or wherever. We'd like you to come in regularly every single week. Or we will give you a smartwatch, and your only requirement is you wear it. There'll be ask to charge it every night, and then it'll ask you to do something called a 6-minute walk test. And then periodically it'll ping you to take your meds. And if you don't wear it, we're going to call you, right? Because we know you're not wearing it. That was it. I mean, it's a pretty simple. So you have that choice. Well, you can imagine, even pre-COVID, a lot of people took that, including seniors and folks who people had said never would use technology, because it made the choice was so much better for them, and it was supported by the clinicians, and the clinicians felt that they were getting better care. In fact, one of the learnings was we even identified individuals that had issues beyond cardiac rehab. Like one of the individuals, they were inconsistent in their performance. And in talking to them, it turns out that they actually had depression. And then that led to a significant, that would never have been picked up had there not been sort of this ongoing surveillance. But in that context, the person then was brought to receive treatment for it, and then is now sort of back on track. But these are the things that happen when you start these programs. You learn and you get that connection with the patient, and you can start really helping them in other ways that go beyond the medical condition that you had originally started with.
That's amazing. Yeah, it's maybe opening up new channels of special information coming from the patient that you might not have seen before, because you have this new modality of interacting with people in their real life, as you said. The consumer expectation of having services follow them where they go, instead of having the requirement of the consumer going to a patient portal, is a really interesting shift. And it seems like we need to tell that story more to lawmakers and regulators in order to make virtual care something that we can continue to practice beyond this emergency period. So I'm wondering, what can we encourage health systems and other virtual care innovators to do to collect data to show that virtual care is benefiting both the people providing care and the people receiving it?
Well, I think the first thing is that we have to look beyond where we're at today with virtual care. Virtual care, because of the pandemic, has been viewed as an alternate replacement of the in-person. It's just done with a telemedicine, with just a video consult, so to speak. But where we want to go is we want to add capabilities to that virtual visit that we couldn't have done in a typical visit. So let's imagine a scenario where in that context of the virtual visit, this is real. I mean, that entire conversation is captured and is brought into the medical record. That's new. That's different. That's something that's value added for the clinician. Let's imagine that as part of the virtual visit, we can now bring in consultants from around the world real time and have a direct virtual consultation with multiple different people, all looking at your record and talking about the specific things that are specific for your case. In fact, we did this with the National Health Services in the context of individual with a HoloLens walking into a patient room, and in the back they had actually all these specialists and all the whole entire care team behind them. And then they were able to pull up through the FHIR APIs and other tools, mechanisms to see the x-rays and the images and be able to collaborate right in front of with the patient. But that was one in the context in the person was in the hospital. But now we can envision the same type of approach, but perhaps maybe through Teams, where a patient is now being able to see all that information, see all the consultants, hear real time. That ability for us to be able to do that doesn't occur when you have a single visit with the clinician. And this is where I think we need to start rethinking, how do we make virtual something that is better than what we currently do today? What we've done also is we've been thinking beyond the patient-doctor, that single encounter. We talked about virtual cardiac rehab, which is a sort of a comprehensive program across multiple weeks. But we could also think about the other interactions that occur pretty regularly. A doctor curbside with another doctor, these consults. What we can do with the consultation is be able to then take and do information exchange that we hadn't done in the past. Again, using FHIR APIs, we can actually now have a conversation about a person and their MRI and all be looking at it together. Couldn't have done that if I wanted to text them. I can't text them an MRI image, but I can do that now with some of these new capabilities with Teams and the FHIR APIs. If I wanted to actually do what I'll refer to as a virtual rounding, where you're actually going around to all the rooms. You can have cameras set up and you can literally do all that. You can do virtual sign-outs, like nurses signing out to the next staff all virtually. You could do virtual tumor boards. We've been seeing all these examples of how workflows that had traditionally been done in person through sort of a general approach can be made better, more efficient. As we start thinking about how we do that, we can add more functionality to the digital to make it smarter. And ultimately, you talked about this earlier, the natural language processing of one of them, which is voice, but the other area is around text analytics. We have been spending a lot of time looking at all the information that can be gathered from written progress notes, through text messages and other types of things, through abstracts in studies. Pull all that information and then start making sense of all that so that we can actually provide real-time decision support for clinicians as they are in the process of talking to the patient about specific topics. And this is where healthcare is going, where we're starting to do a lot of this real time, as opposed to having that conversation and then somebody reviewing the chart later on and saying, oh, you should have done this. Oh, if only you would have done this at that time. We can now do this in a way that's more streamlined, workflow compatible. But it means that we have to start digitizing things, making them interoperable so that we can understand how they fit together, apply AI on top of it, and then push it out in terms of decision support.
So that's really interesting. The organizations that are working on measuring quality, like NCQA, and standards organizations like HL7, they're trying to work together on using the FHIR standards and other things to digitally assess quality, and they're still maybe in the retrospective mode in a lot of the things that I've been exposed to. But you're saying, move that into a real-time experience and make it part of clinical decision support, where the care professional can do something, right there in real time.
Yeah, it could be applied for quality. It could be applied for safety. It could be applied for even reimbursement. Think about this. If let's say you're going to be enrolling a person for a particular new drug or a new type of treatment, and that you need certain types of things in place, the X-ray or the MRI or certain lab results, before you even let that patient go on their way, it could run a quick analysis and tell you, oh, by the way, the requirements will be that this person has to have a calcium level above this or a sodium, whatever the parameters are. And so that what's the expectation. Oh, I didn't even order the chem panel, or I didn't even order the X-ray, right? These are the types of things that can avoid down the road calls from whoever is saying, oh, by the way, that was denied or it's still pending. We see so many of these inefficiencies today because of the fact that we are having somebody review the information that's been done and then apply some kind of a checklist, a predefined checklist of things to find gaps. And then when they get the chance, contacting them. And then by the time the other person gets there, days, if not weeks, have passed. It's such an inefficient process. We can automate that, and we have the tools today to do that.
That's great. I talk to a lot of health technology entrepreneurs who are trying to break in and work on things like this. And, they're really smart technologists. They may have, a medical or a bio background, but they don't necessarily have a lot of familiarity with, government regulations, accreditation, the administration and finance of healthcare. And I see them get somewhat easily discouraged, once they start to encounter some of these barriers to wonderful creative things. What would you say to an entrepreneur who is trying to bring a new product to market, trying to build a company and break into healthcare? How could they succeed? Is it patience? What are your words of wisdom for those that were trying to get into health technology?
And part of it is timing. The reality is sometimes great ideas and great concepts are not at the right product at the wrong time. And so what we need to understand is what are the things that have opened up those new possibilities. When you think about just in general, how is it that certain companies have been able to be so successful? Well, the internet was a key pivotal event. Without the internet, it'd be hard to be able to envision some of these companies, kind of making that step forward. And then you see other key steps along the way. In healthcare, we've had a pivotal event here, and that is the CMS interoperability piece. Because what we're now doing is we're able to unlock some of those data sets that have in the past only been proprietary or reserved for specific uses, to the point that the patient, the consumer, has direct ownership or the rights to them. Now we'll see how it plays out, because there's not the final book is not yet written on this, but what we're seeing is that this is the opportunity for us to start looking carefully at that, and then understanding if the consumer says, I would like to have a service that benefits me, in which this information needs to be pulled from these records and run through that service, and they grant authority and authorization around that. That creates a new business opportunity for entrepreneurs that wasn't there in the past. And so we need to start, looking at some of these key pivotal moments. Prior history-wise, just looking at meaningful use. When meaningful use hit, companies were, EHRs were around for a while, but we didn't see that adoption, and we didn't see the whole ecosystem of systems and being built all around the EHR until the meaningful use came out and it became enforced. And I think this is really where we're starting to look at opportunities, whether the innovations are occurring through technology, which we're now starting to see a significant number, with the voice AI, that's creating a huge, one of the things I talked about was the efficiency of getting into the medical record. I actually think that's the tip of the iceberg in terms of the voice AI component, because once we understand the context for what actually is happening in the conversation, we can then run the decision support. We can build algorithms around, as I mentioned, quality, safety, reimbursement, and a variety of other ways that we can now enable better care real time. And so, we need to just start recognizing that with every new innovation that comes out, some of these are pivotal in ways that will open up possibilities for us to be able to build businesses and services around. And as long as it's geared towards creating new and better value than what exists today, providing better care at lower cost, that's consistent with what everyone wants. And then the next question is, how do we get that system in place so that it's both workflow compatible for the clinician and then lifestyle compatible for the patient? And I think that sometimes gets forgotten. Sometimes people focus on one versus the other. They're like, oh, the patients love it. But the doctor's like, well, I don't get all that data. It's just too much. This works great within our EHR. It's like, well, the patient's like, well, I don't think I'm ever going to access that tool because I have to, do all this stuff and enter this stuff manually. And that's just, so we have to find that balance where it does both. Okay.
Well, that's great. It's really helpful to hear everything that you've said today. It's really illuminating. I haven't heard that lifestyle term. I've thought about workflow a lot, and I've tried to come up with the other side of that for the consumer. So really illuminating to hear what you have to say about that. And I just want to open up the floor. If there are other folks that are tuned in, you can put in a question in the chat, or you can click request and share audio and video. It'll be in the upper right hand corner of your screen there. And then you can jump on the stage here and ask some questions. And I guess, while we're waiting for those folks, one thing that was really great about the 21st Century Cures and information blocking rule that was finalized this year is that, okay, we have some clarity around FHIR and, the United States core data sets for interoperability. And, so we know that here are the standards for information to flow from the EHR to the patient, or from CMS similar rules around payer systems to a member of a health plan. And one of the challenges I see is that when the patient is doing something like, let's say, we just talked about a rehab program, where they're wearing a watch or something, getting that data back into the record, well, these regulations don't necessarily cover that. And so, what's your advice or thinking around how you would guide entrepreneurs to solve that problem of writing back to an EHR, where typically maybe you have to fire 100 business rules when you write data to an EHR?
Yeah, and these are all great questions, and I think it ties into the fact that while we have made huge strides with the 21st Century Cures Act and CMS interoperability, and even with FHIR, it's just the starting point. It opens the door for us to be able to do more, and we need to do more, both in terms of continuing to build out the technologies, but also the rules and regulations, and we have to think about how those will get enforced. So I think that if we stopped here, unfortunately, it's not enough. But I don't think that's going to be the case. And you just see the momentum and the interest in this, and if more people find value in what's happening, you're going to see a greater public support around this, and ultimately a drive towards more integration and interoperability. But as of today, there are still many opportunities for us to improve on that. So hopefully we'll see more progress within the next year or so.
All right, we have a question from JR. What are the biggest challenges, or what were the biggest challenges in making cloud for healthcare a reality?
Well, one of the things is when you're and I would say this is just in general, when you are have built a business, or you've got certain products and you've got certain things that are moving well, to introduce a brand new concept, the one that's been, people have been asking for, but you haven't necessarily tested or validated this in the level of confidence, because is a disruption to your existing product lines. It exists disruption to a lot of things that you haven't even thought of. That change management is always a challenge. But I think one of the things that we did at Microsoft, which was rather special, was that at the top, Satya Nadella, our CEO, said that we want to lean in. We don't want to be a generic cloud. We don't, provide cloud services and platforms. We want to be able to solve industry problems. And to solve industry problems, we're going to leverage the full repertoire of all the things that we have, and we're going to make this something that industry can use. It's workflow compatible. It's things that data flows naturally. And we're going to make sure that that's something that we deliver on. And so the goal at Microsoft is actually to build out several, multiple industry-specific clouds. It just so happens that during COVID, the urgency towards addressing COVID and virtual care kind of put us first in line. So we were very fortunate to be in that position. But it is actually something that across all of Microsoft, you're going to see more industry-specific clouds being launched.
Well, it's great that one of the silver linings of this horrible public health thing that we're experiencing is that it is accelerating some things with technology, and especially telemedicine. Jay Larson asked here, when do you think telemedicine, and I'll add a friendly amendment, virtual care, because it might not be real-time, one-on-one, face-to-face video type interaction. When will it be mainstream and the norm for medical visits as opposed to in person?
Yep. Well, let's kind of reflect on what happened and kind of learn and discuss like these key observations. The reason why everyone jumped towards telemedicine initially was because of concern for COVID and the spread. And they just did, in fact, even some of these places, they were shut down. they couldn't literally have people in the facilities. So this, for a variety of reasons, they were forced in this path. What happened because of the fact that they were forced is that clinicians learned how to use these tools, and most importantly, patients did. And when patients began using it and understanding it, the technology, we continue to advance and make that better. And what we've been doing on Microsoft has two ends. I talked a lot about, some of the telemedicine capabilities that we've built for Teams, for instance, recognizing that we need to make Teams something that, ties directly into the electronic health record by launching it through Epic and things where you could actually take the medical information from a conversation and bring it back into the HR, doing scheduling and bookings apps, and, direct ties in from bots to telemedicine, and all these type of enhancements to this to make it something that could be truly utilized by a clinician. On the flip side, we also spent a lot of time thinking about how do we make this accessible by patients. It's got to be on mobile apps, different iOS and Android. It's got to be on web. It's got to have a great seamless user experience. We've got to make it fun. We've got to enable, discussion rooms. And so all the consumer elements to that also were very important. And so as we've advanced that, we have also been seeing a greater level of adoption. And we anticipate that when we make that easier to the point where it is as seamless on the consumer side as well on the provider side, then you've created parity, if not a greater acceptance towards the telemedicine. But as I said before, if we stop there, then we've missed the opportunity, because what we can do now, since it's digital, we can do things that we couldn't have done with the in-person. We can have virtual, we can have a whole team of people accessible real time with specific questions. You could have an opportunity where you can run text analytics on certain types of conversations. You can pull up images and share that directly with patients. And so there's a whole series of different things that we have not been able to do in person or have not done consistently, but now we can actually enable that through these digital tools. And that will be the opportunity for us to start finding that there'll be a greater desire to be able to become more mainstream. Now, that's from the technology and experience standpoint. Now, the other issue is around reimbursement. So reimbursement clearly needs to be keeping pace with all of this. I think we've made some great strides. We're going to have to continue that beyond the pandemic. There's indications that will occur, but it also has to be in line with kind of how people get paid. So you put all these factors together, and you're going to start seeing a normalization and an expectation that this will become the norm. But we're heading in that direction. In many ways, it is the norm right now. It's just a question of hopefully when COVID subsides, will there be still that continued desire? We anticipate, and I think most experts do, that there will be a significant number of people that will want to continue through this. It's just a question of how much we're able to do to provide that goes beyond making it just simply a video consult.
Right. One of the things that I have heard in my advocacy work, talking to congressional staffers who are wrestling with this, Senator Grassley is going to be retiring. Is he going to pass a major telemedicine type bill? And there are concerns about something you talked about in the very beginning, related to disparities in our society. And so there's some concern that the digital divide will leave some people out. But some of the things that you've talked about, I think, are actually encouraging for that. The ability to collaborate between a diverse set of care professionals and ancillary community-based organizations. I'm imagining like an organization that works on homelessness or food insecurity or housing insecurity. All of a sudden, they can be a part of the care team, and they can be seeing whether or not the clients that they're serving are getting their social needs met. I wonder if you could say more of that to help address this concern that people have about telemedicine enhancing the digital divide and those disparities.
Yeah. So clearly, these are topics that go way beyond technology. But one of the things that we have seen, if you are going to implement technologies that enable a lot of this, people are going to need to have access to broadband and affordable broadband. And so what we learned is that if we were to lean in and help support programs, in fact, that's one of the programs Microsoft is called Airband, across the nation, trying to enable, I think it's like 25 million individuals to gain access to broadband that hadn't had that previously. What we're doing is we're trying to put that infrastructure in place to enable a lot of these technologies so that we can even the playing field, help people that really do need it. Now, there's also an element of affordability, and we're going to need to continue to address that issue of, for the folks that can't afford it, how do you enable them to be able to gain access to that as well? And I think that's probably that goes, to the government level, that goes to philanthropies. There's a whole series of ways that we might want to think through that. One of the other areas that we've been thinking a lot about is, training individuals to these skill sets. So, we actually have a whole program on digital training that on the virtual care tools. It could be, just basic technology itself. There is going to be, in all likelihood, a big shift during and post-COVID towards new skills that are going to be required for people to be able to survive. And because of that, we need to start thinking about how we train that workforce, the new workforce, that digital workforce. So that's those are some of the key at a high level. But we're also spending time thinking at the individual level. And I talked about this before. When an individual has issues related to anything from food insecurity, housing, job / income, these are huge social determinants, social influencers of the health that oftentimes, the best we're able to do, and I've seen this many times, is we give them a checklist or give them a list of links and phone numbers, and we ask them to see if they can call them up, or maybe you do a social worker consult. What we'd like to be able to do is we'd like to be able to individualize those services. And again, as we go through this process of looking at what are the things that could be most beneficial, the programs, the support mechanisms, we may be able to then provide individualized recommendations to people that help them down on that journey. And sometimes it's, again, right information at the right time. If I'm that patient who has missed the last 4 appointments because of transportation issues, and then all of a sudden that's been introduced during the conversation I had with the receptionist, and they said, we're going to schedule a ride share to pick you up at this time. I'm like, wow. I mean, first of all, I would never have in a million years have thought that you would pay for a ride share to do that for me. And you're doing that in the context of this visit and then the follow-up visits. I mean, these are the types of things we just need to think through. How do we, as organizations that want to achieve better outcomes, remove some of those barriers? And sometimes it's as simple as things like that. And so those are the things that we can do at an individual level. So kind of big picture stuff that needs to occur, and then, smaller things that we need to do.
Okay. It's really cool to follow your career and all the work that you've done around virtual reality. And, one of the questions here is, what do you see next for the HoloLens and its applications for future medical benefit?
Well, I shared with the example that's happening at the NHS where the HoloLens is being used in COVID cases. We are also seeing it being used in a variety of cases specific for the OR. And in fact, we have announced it's on one of the HIMSS blogs, also now just released today or yesterday, a project, an initiative in collaboration with the VA, Palo Alto Medical Center, Verizon, and a company called Medivis and Microsoft, a program where the surgeons will be using HoloLens. And during that process, it's sort of like a multi-stage component, one of which they'll be able to collaborate with other doctors, similar to what we saw before. So you can envision maybe a complicated surgery, in which case you've got, it doesn't even have to be a junior surgeon. It could just be a surgeon that's never done this type of procedure. And then in the background, you've got your you're super trained, like the world's best, surgeon in that category watching and helping guide you. Then on top of that, pulling medical information directly from the medical record through voice and being able to pull that into that. This is actually a program that we're going to be rolling out at the VA Palo Alto Medical Center and with a 5G network. What we want to do, and this is where some of the other companies have been innovating, is looking at the specifics on the anatomy and being able to then identify landmarks and things that could help guide. I'll call it like a GPS system for the surgeons and help them in that process. That's a little bit more future state. We have already seen that type of digital innovation being done, not necessarily real time in surgeries, but also done in the preparation for surgery. So people have actually done and used these tools. So we know that that is possible. We just haven't applied it in terms of exactly during a surgery. But this is really where we're heading. We're heading towards an ability to do similar to what we did before, which is create these new virtual environments that allow for collaboration, data information to be pulled in, and then on top of that, clinical decision support. And so those themes can also be applied in terms of HoloLens. And we're seeing some really amazing things that are going on. One other thing that I wanted to highlight is that there are companies and partners that we work with that have done these type of procedures for and have proven some great results relative to different types of cardiac and procedure, implants and radiology type of procedures. A lot of that has been done. We've seen medical students also be trained using HoloLens. So really exciting opportunities for HoloLens across the board, way beyond just the headset and providing a great visual experience, but the opportunity to improve care and outcomes.
I know we only have a few more minutes of your time. It looks like we have another question here, if you're able to take it. This is from Mike Larned, and he asked, what is the future of Azure commoditizing common population health models, for example, predicting high-risk patients for preventable emergency department or high-risk readmission, and what are some of the challenges there around Azure helping to predict which patients might be running into trouble?
So this is exactly what we're looking at as well. We do believe that once you actually have a data set that's robust and granular, that allows you to be able to look at populations of patients, we can then do drill downs that we've never done before. So for instance, imagine if we had a population of, and I'll make this up, of patients that have all had COVID-19. And we're curious within that cohort, who's going to have long-term sequelae? Who's going to be admitted for the hospital and maybe they're diabetics with that, or hypertensives with that, or patients with heart failure. Are they at higher risk? These are things that we don't know the answers to. Or even if you had an existing cleaner population, non-COVID, just a diabetic with a hypertension with a certain age group. What we can then do, because we now have an ability to pull information from the medical record at a very granular level, map them out, we can actually then look for those correlations with the clinical outcomes and then cohort patients and test those algorithms out and then predict what those opportunities are based on other patients like you. So if we've got older individuals with certain comorbidities and certain types of physiologic parameters, and we know that you kind of fall into that category, your trajectory falls into this group. And so that over time, our expectation is that you will hopefully continue down that path. But if, let's say, we were to see you falling off the grid because of other parameters, we might then want to intervene more aggressively. And that type of modeling is stuff that we're already building out, some of the tools. I'd love to be able to talk with Mike and others that are interested in this. But we do think that once you actually understand patients at the granular level and you can store and manage this at the higher level, we have an ability now to be able to provide smarter predictive analytics and ultimately better interventions.
Do you have time for one more?
I do, yeah.
Okay, so this is from Dejan Nanov. Uh, he's observing that the focus expressed here seems to be on empowering providers. He'd like to hear more about your thoughts on the importance of patients' ultimate ability as individuals to receive, own, collect, control their personal medical records, as opposed to incumbents exchanging medical data. And I think we were talking about this earlier with the interoperability rules with patients now being able to have access to their data. So, maybe you could reemphasize what's the new landscape now with data. It's going to new places with interoperability.
Well, if we think about what is the real value of being able to have your access to your own information, it starts with being able to share that. And so that's great. I think the CMS interoperability rules will give us the ability for individuals to gain access to the information and share it to whether it's a provider or an insurance company or it's to whoever they feel it's appropriate to share that. Why would they want to share it is really the next question. They want to share it because they believe, and in many cases this is absolutely the case, that by sharing it, that individual or that provider or that organization is going to be able to use that data and provide them a service that they couldn't have gotten had they not been able to share that, or do it in a safer way or more effective way. And that is where the opportunity for us to start thinking about how we go beyond simply the ability to share. If it's just about sharing, again, the value proposition is somewhat limited. I think most people will only share during certain time periods. But if it's about, let's say, enrolling in a special, more advanced program around diabetes management that's been proven to be more effective because it's individualized, and we've been able to take this information, similar to what I shared before. Let's imagine we had built those population health management modules, and we were able to stratify patients based on more granular factors than we've ever been able to capture before, potentially even real-time, data feeds. And then from there, be able to generate information and support for not only providers, but really for patients and their caregivers. That creates great value. If I'm a caregiver for my elderly parent and I want to know how to take better care of that individual, it may make sense for me to start enrolling my grandparent in a program, working with the grandparent to enroll in a program that allows us to be able to ensure that the patient's safe or the individual's safe at home. And that that we've assessed everything from medical to safety issues. These are all opportunities for us. Once we are able to have shift the ownership of the data to the individual, then the decisions on how that can be applied need to go towards services that are relevant and consumer centric. We haven't built them out today, largely because of the fact that these services. There was really no opportunity to deliver on it. People didn't have access to their data, and they didn't have access to a significant part of their data that was meaningful. Now we're starting to get to the point where a lot of that data can be accessed real time, and that's really exciting. And now being able to put that together with other stuff, I think we can create more meaningful services than exist today, and that's where people will start wanting to take advantage of.
That's great to hear and encouraging, and I really look forward to patients getting the care that's right for them, based on this real-time data flowing to them, so that they can ask for the care that's appropriate at the right time, and maybe say no to care that's not right, and do as much for themselves as care comes home with remote patient monitoring and other things. It seems like a bright future, and you're a great spokesperson for it. Thank you for coming to the Idaho Technology Council Megaspark event and sharing all of this with us. I hope that all of you listening to this are equally as enthusiastic and want to get to the great work of advancing health technology to help the patient, help their providers avoid burnout, and make the healthcare system more affordable, higher quality, and a better experience for all of us.
Wonderful. Thank you, David. Pleasure to have been here.
Thank you.